Uh, First of all, I'd like to congratulate all the speakers of today's morning session. They have made my job a little easier, but specific ventilator strategies in cardiogenic shock. There's not much data or not many studies on this, so I will try to enlighten upon the basic principles as well as how these children should be ventilated and the principles governing them. To go through a few definitions, I know this might sound like a repetition because a lot of it has been spoken about yesterday. The mechanisms of shock where inadequate tissue perfusion is due to predominantly inadequate oxygen delivery and substrate delivery. Similarly, along with that, you have inflammatory mediators, there's microvascular changes going on, and eventually what happens is you have clinically multiple organ failure which sets in, and then hypotension in the later stages. I will not dwell upon the various forms of shock in children, but specifically in relation to this topic today, cardiogenic shock. This is systemic hypoperfusion secondary to a severe depression of cardiac output and sustained systolic arterial hypotension despite elevated filling pressures. It's a bit of an oddity and an odd feature for this, but this is a specific situation which sets in a variety of clinical entities. In this graph you can see in this chart various parameters as well as various causes of shock. In the more common hypovolemic shock, you have a fall in preload with a fall in cardiac output, high SVR and a low SVO2. And in cardiogenic, you have a high or normal preload with a decreased pump function predominantly and raised afterload, and tissue perfusion is also decreased. In distributive, it's a bit different, but I would like to highlight that despite normal filling pressures, you are hypotensive because of a different sort of clinical entity here. There are several etiologies. Dr. Amit Verma yesterday highlighted many etiologies of cardiogenic shock in children. But predominantly, to summarize as well as list the more important clinical entities that we face, is one is that of pump failure, which most commonly happens in the particularly neonatal population, first 2 weeks of life, ductal dependent cardiac lesions, both right heart and left heart, obstructive lesions right from hypoplastic left heart to interrupted aortic arch, and similarly lesions on the right heart. And you have myocardial failure due to a variety of reasons. We do get epidemics of clusters of children who get admitted to the PICU with myocarditis, and this specifically occurs during the winter season and then early monsoon season. And these children behave very differently from those that have infiltrative disorders or other etiologies of cardiogenic shock. Also important is unrecognized sometimes is electrolyte abnormalities which can cause cardiogenic shock, typically hypocalcemia, hypomagnesemia. And post-pump, those units where they perform cardiac surgery, this is a very common observation as well as it's the norm that you have some degree of cardiogenic shock in the initial postoperative period which resolves spontaneously as adaptive mechanisms kick in and play a role. More or less common is tamponade, again most commonly sees in cardiac surgical units rather than in the general pediatric ICU, and of course abnormalities in heart rate, typically the tachyarrhythmias where you have cardiogenic shock setting in. There is a graph which shows the cardiovascular effects of mechanical ventilation. It's I don't know if you can see it from the back, but in essence, when you institute mechanical ventilation in a child, you have a high airway pressure which is raised and also pulmonary overdistension. With these two mechanisms, there's a cascade of events which does take place: reduced venous return, reduced preload, as well as reduced cardiac output. And similarly, you have a similar situation. The overdistension of the lung itself does cause a cascade of events leading to cardiac output which is reduced, and simultaneously the higher transpulmonary pressure can actually increase RV afterload and also cause reduced coronary perfusion pressure. So the mechanical effects can be quite varied, and in the individual patient needs to be addressed as well as treated appropriately during the course of mechanical ventilation of the child. So a study which has highlighted the important implications of the cardiopulmonary interaction, specifically with a rise in high airway pressure and volume. You do see a picture of a decreased preload on the right ventricle, increased afterload, and reduced contractility. The similar effects are seen on the LV where there is reduced preload, but however you see an decreased afterload, which is more of a beneficial effect. Also, there is actually direct compression of the heart in the cardiac fossa due to institution of positive pressure ventilation. Early ventilatory mechanical ventilation is usually the rationale in children with cardiogenic shock, particularly because there are many reasons why children are intubated early. Any child who has got a poor response to fluid therapy as well as inotropic therapy needs to get intubated. And early intubation does decrease the cardiac workload by as much as 30% in various studies. Whichever modality of ventilation which you use, pressure control or volume control or PRVC or any of the other modes which are come into existence, the effects of PEEP, increasing PEEP, which is known to be beneficial, is reduction in the left ventricular afterload, and also most of these children have pulmonary edema of varying degrees, from mild to moderate to severe. So increasing PEEP definitely helps clear pulmonary edema. So there is a dual effect, a dual advantage of intubating these children early and instituting mechanical ventilation. The strategy which is most commonly accepted as well as followed in most centers is that to use the lowest effective tidal volume to achieve your gas exchange variables of oxygenation and ventilation, and a slightly higher PEEP than normal, but not more than 10 centimeters. Various studies do indicate that, not to use a very high PEEP. Obviously, in the initial stage where you have an ARDS-like picture setting in, typically in children with non-infectious etiologies as well as any other condition, using a higher PEEP initially and then backing off as soon as you have adequate lung recruitment will definitely help. You will need to use shorter inspiratory times, and most of these children are quite sick, very fussy, irritable, so they would need some form of sedation, preferably fentanyl or midazolam, which does not have, either of these don't have much of a hemodynamic compromise. It's a favorite diagram which all of us have been taught right from our physiology days, the Frank-Starling curve. You can see here in the decompensated heart, we try to move the curve from point A to point B to achieve better myocardial contractility and cardiac output. The next few slides, I will be only highlighting the major principles or the principles of management of cardiogenic shock. Predominantly, it rests in two different categories. One is to minimize myocardial oxygen demand. How do we do that? One I showed you in the previous slide. By early mechanical ventilation, you are able to reduce the load on the heart. So early intubation and ventilation would be a norm. If these children are hypothermic, try and get the temperature back to a normal core temperature and maintain it as long as possible. Correcting anemia is important because that's the main determinant of the oxygen carrying capacity of the blood, and that's going to improve oxygenation as well as myocardial function. As I mentioned earlier, sedation would be required of varying degrees, and there's a whole host of drugs that you can use, and whatever your unit protocol and sedation protocol follows, I think that would be fine. The next other important thing is to increase the myocardial performance. This can be done if the child is in shock and a bit hypovolemic. You can use small aliquots of fluid, try to optimize preload, get the preload to an optimal stage, correct any arrhythmias. Fast heart rates typically are not well tolerated by children, so if the child is in SVT or any other tachyarrhythmia, try and correct it and maintain a normal sinus rhythm as far as possible. As I mentioned earlier, electrolyte abnormalities, these are often diagnosed, typically hypokalemia, low calcium levels and hypomagnesemia. So these need to be addressed and adequately corrected, and if you can maintain a normal fraction of ionized fraction, among these which is not mentioned here is hypoglycemia, especially in the infant or the small neonate, where that can impact on myocardial performance, and overall your shock management will not be effective if you do not achieve a normoglycemic status. The other important aspect is to reduce afterload. We have an array of drugs to do that, the SNP, nitroglycerin, and various other drugs. And we have a whole host of inotropic drugs, which I'll be touching upon some of them very briefly, to improve cardiac contractility. So with these two mechanisms of maximizing myocardial performance, optimizing preload, and various other functions, you can achieve your goals. The last few slides are towards the inotropes which are commonly used. I will not go into all the details. The most commonly used is dopamine, which is given as a continuous infusion. Typically in the neonate and infant, the effects can be quite variable. It's not absolutely predictable, and we have to titrate with the response, and increase the dose or reduce the dose of dopamine as required. Common doses which are used, the lower dose of 0.5 to 2 micrograms per kilogram per minute. The concept of renal dose doesn't exist any longer, so most intensivists, most units use and start off with dopamine at 5 mics and rapidly increase it up to 10 mics per kilo, 10 mics per kg per minute. The more important drug that is most commonly used is dobutamine, which is a pure synthetic inotrope. It has a direct action on the beta-1 receptors, augments cardiac output by increasing stroke volume, has less effect on heart rate, blood pressure, and vascular resistance. Dobutamine has been used successfully in various clinical states. Typically, children with myocarditis, open heart surgery, and neonates and infants recovering from asphyxia. The common dose that is used is, I'll not get into this, but the ideal candidate is the one for dobutamine is a child with low output cardiac status with cardiogenic shock, where there is elevated filling pressure and a normal or only slightly reduced blood pressure. Other commonly used and accepted drug now is milrinone, which all of us are quite familiar with. It's a selective inhibitor of phosphodiesterase 3, and it produces vasodilatation of both pulmonary and systemic vasculature. Unit protocols, most units use a loading dose followed by a continuous infusion, and milrinone has a positive inotropic effect on the myocardium. It has an effect what we call as lusitrophy, which allows and augments left ventricular relaxation. Milrinone produces much greater reduction in systemic vascular resistance for a given degree of improvement in the inotropic state as compared to dobutamine, and blood pressure is well maintained even in the face of a reduced SVR. In children with pulmonary hypertension, typically this is also a commonly used drug, not only in cardiac patients but also in birth asphyxia and other pulmonary hypertensive crisis, where it reduces pulmonary vascular resistance and decreases the left to right shunting. In cold shock, milrinone is commonly used to increase cardiac contractility and have a role in improving. The combination of inotropy as well as lusitropy is very beneficial, and typically children with post-pump myocardial dysfunction or myocarditis benefit from this drug. Other drugs which are commonly used is epinephrine. In the low dose, it reduces SVR and PVR. I will not get into the details. In higher dose, it increases it. And the usual infusion rates are anywhere from 0.05 to 0.3 micrograms per kg per minute. You must remember that very high dose, 1 to 2 micrograms per kg per minute, can cause marked vasoconstriction and reduce blood flow to any of the vital organs. Norepinephrine, again, it's a pure alpha effect. It causes peripheral vasoconstriction and causes beta-adrenergic stimulation, inotropy, dromotropy, and chronotropy. Most commonly used in septic shock, it's also used in myocardial failure post-open heart surgery, and the dose that's recommended is 0.05 to 1.5 micrograms per kg per minute. The dose obviously has to be titrated. To summarize my talk, the etiology of cardiogenic shock is varied in children, different age groups, and some of the disorders which we face in clinical practice can be in an epidemic nature. Individualizing therapy is essential. This is very important. A knowledge of cardiopulmonary interactions is required to understand the better role of mechanical ventilation and use the appropriate ventilatory strategy to achieve adequate ventilation and oxygenation. Bedside echocardiography and hemodynamic data, which has now become more or less common in most of the advanced centers, is crucial to understanding real-time cardiac status, which will give us fine-tuning of inotropes as well as ventilation. And the use of both inotropes and vasodilators as appropriate improves survival. The ultimate outcome obviously depends on a multitude of factors, whether it's an acute process, a chronic process, is there any other multi-system involvement, etc. Thank you for your time.